Everyone, my name is Joanne Lagande. I am a board member with Haitian American United for Progress, and this is Hope Goes Pink in honor of Breast Cancer Awareness Month. We have a very informational session for you this evening with an expert who will share with you all of the necessary information you need for your own health and for the health of others. HOPE's program is done in honor of, again, as I said, Breast Cancer Awareness Month. And for those of you who may know, we're also doing a walkathon, and we'll be sharing that information very soon. On Thursday, we also have Hope Goes Purple for domestic violence awareness. So please join us also on Thursday at 7 p.m. On October 28th, we also have an amazing program celebrating immigrants in honor of Hope's 46th anniversary. As I said before, this evening, we are incredibly honored to have an amazing guest with us this evening. Our guest speaker is Dr. Louis Joseph Auguste, a surgical oncologist who will be giving us so much information on how to remain healthy with breast cancer. We have our HOPE staff who will be doing a presentation, Sabi Laurent, community health worker, and of course, our producer, Melinda Placide. HOPE's mission. Many of you know that HOPE has several offices throughout our area. HOPE began as a volunteer-based organization 46 years ago, focused initially on responding to the needs of Haitian immigrants and refugees. We've now expanded and offer so many services to newcomers and citizens alike throughout Queens, Brooklyn, and Long Island. HOPE is really a home-based organization. We are here to support all of you. We've even outgrown and gone to all over the community, beyond the Haitian community. HOPE is a not-for-profit community agency that provides services that strengthens and empowers families to live successful lives. We offer so many meaningful and culturally relevant services to over 15,000 individuals and families. We support people in need. With its record of providing culturally and linguistically competent services, HOPE has established trust over decades with the immigrant communities it serves. And I'm sure you are here this evening because of your relationship with HOPE. So tonight, Sabi will be sharing information on the services that HOPE provides. Sabi Laurent is a community health worker based in Queens, New York, but originally from Thomasin-Pétionville. Sabi always has a passion for helping his fellow Haitians and has a long history of volunteering and working with vulnerable populations, both in Haiti and in Queens, New York. He is currently a community health worker and one of the many health support services that HOPE has to offer. He finds himself working with the underserved every day to give them access and resources that were previously unattainable and making a difference in the community. Welcome, Sabi.
Thank you, Joanne. I'm here to present the different health services that we at HOPE we offer. And we offer different health services such as maternal infant health, domestic violence counseling, and also VARI, which is Access Resources Initiative. Maternal infant health, we conduct workshops on health education. We connect parents to resources like diapers, wipes, and packing places. Domestic violence, we conduct case management with survivors and connect them to resources that empower them and protect them. We also raise awareness to workshop in healthy relationship. And we have VARI, which is Access Resources Initiative. We connect people to resources that allow them to have access to the vaccine, COVID-19 vaccine. We address misconception. We schedule vaccine appointment, and we host vaccine site to anyone that needs services. They can contact HOPE. And this is last year, we have like a few of our members that got back the vaccine. So we still doing it. on a like on a weekly basis. That's our staff here. We conducting, we doing outreach, and we helping people get the vaccine, and we make them feel comfortable and by getting the vaccine. Thank you.
Thank you so much, Sabi. And right now, with everything that's going on, vaccination is definitely important. And please reach out to us at HOPE so that you can get vaccinated. We are here to support you, and we are here to ensure that you remain healthy. And having said that, again, I am super excited and honored to introduce to you Dr. Louis Auguste, who is a surgical oncologist. Dr. Louis Auguste is a doctor primarily located in Manhasset, New York. He has 47 years of experience. His specialties include surgery, head and neck surgery, oncology, and surgical oncology. And Dr. Auguste, thank you so much for informing us. Whenever you come, you offer us such important information, and you empower us to take care of ourselves. And so I'm so excited to hear what you have to say today.
Thank you very much, Joanne, for this introduction. Again, it's my pleasure to be here. Last year we did the program, and it's always a pleasure to have that exchange with our members of the community, and because like they say, knowledge is power, and I think the more we can share, the better the community will fare from a health point of view. So this year, I wanted to talk about the more of the psychological aspect of cancer care, because we talk a lot about the surgery, the chemotherapy, the hormonal therapy, the radiotherapy, but all this is given to a person, the human being, has needs, that has worries, that concern. And then my goal today is to introduce you to some of the considerations that are really of great importance when going through this process, either personally or while providing support to one of our friends or family members. So just some statistics in 2021. So we're expecting to have 281,000 new cases of invasive cancer. This is 1 in 8 women will have breast cancer in this community. And the 49,000 will be diagnosed with non-invasive breast cancer. And I have to point out that if you look at the statistics over the years, 3 years ago, the number of non-invasive breast cancer was 63,000. So you could see that there has been a drop of 14,000 cases, and that's mostly due to the pandemic, because women have not gone to have their mammograms as they should, and as a result, we're seeing more advanced cases now. Hopefully that would change pretty soon with the vaccination program and the resumption of all the health activities. Also, I have to mention to you that 2,600 women, men will be diagnosed with breast cancer as well. This is about 1 to 100. It's about 100 times more common in women than in men. So the lifetime risk for men is about 1 in 833. So certainly it's a lot less than 1 in 8, but it certainly is not something to ignore. And I'll discuss that later on in the Q&A session. So those were the bad news. The good news is that the survival from breast cancer has improved tremendously. I remember back in the 70s, people were wondering whether they would ever be able to reach 50% survival because most people were dying from cancer. But now we've reached a 90% 5-year survival, which is great news. If the cancer is limited to the breast, and so it's 99% survival. If you spread to the lymph node, it drops down to 85%. Unfortunately, if the tumor has gone to distant organs, has metastasized, then it drops to 27%. So altogether, we have at any given moment 3 million women living with breast cancer in the U.S. So it's great to talk about the macro statistics, how that applies to the whole community, but we have to talk about the personal impact on the individual. So it's clearly that overall people do better with breast cancer, but it depends on a lot of factors. Depends on the tumor itself. Some tumors are aggressive, some are less aggressive. So that's what we call tumor biology. And the stage of diagnosis, whether the person was able to detect the cancer by mammography, or whether the cancer was palpable at the time it was found. And also the treatment offered, are you getting the up-to-date, standard care, or are you being lured into some kind of quackery, some alternative medicine that might not be the best treatment for you? And then so the treatment may be offered, but also has to be delivered. Are you accepting the treatment? Are you receiving it? And that brings you to the other side of the equation of the scale, is that the patient biology. Are you, what's your genetic makeup? Are you immunocompromised? Are you able to fight the cancer? And also, how are you able to interact with the cancer center? Are you able to get there? Are you able to tolerate the medication? Also, are you going to be willing to come back? Because most of this treatment is not a one-time deal. You have to return to the center for repeated treatment. So compliance is very important so that there can be continuity of care. So let's start with the beginning. First, you have to be diagnosed with breast cancer. And it starts usually by a primary care doctor, your gynecologist. They will refer you to have a screening mammogram. And usually they would start at age 40, unless you have a first degree relative that has had a cancer in the premenopausal period. That means very early. So therefore, you might want to start the screening 10 years before the age of the close relative who had the early breast cancer. And so once you go for that mammogram, and it may be normal. Hopefully, most of the times it is normal, but sometimes you do have something that's not clear. They might call you back for additional, pictures. And but unfortunately, sometimes from the get-go, it could be clearly that it's a malignant lesion. The biopsy is done, and boom, it is cancer. So what do you do? First, you have to be informed of the diagnosis. So my preference is not to have this discussion over the phone with your doctor. It's best to have a face-to-face meeting, sitting down, and preferably with a friend or a family member with you to provide support. And face-to-face, you discuss what has been diagnosed. And there are different types of tumors. There are some that are aggressive, some are less aggressive. And they will discuss, what would be the next step, the different steps that would be followed until you can get to your treatment. And in addition to the discussion, it's good to have some written material that you can provide the person at the time of the visit, or you can guide the person to some internet sites, some websites where you can have reliable information. At the end of the presentation, I'll give you a list of sites that really the most reliable, most dependable information can be found. So be careful about, friend, quote unquote friend that would volunteer information. And so not all cancers are the same. Some people might have a cancer that was devastating, and then they were telling you about a bad experience, while you need all your strength, all the courage to face your new diagnosis. You don't need somebody who's going to bring you down to discourage you from going through the treatment. So you need to have a good communicator. It has to be a good, a two-way street. The physician has to be a good communicator, able to break down the medical jargon into layman terms that can be easily understood. On the other side, the patient has to educate herself. He has to be involved. We'll come back to that later in the presentation, but you have to become familiar with your disease, the treatment that you'll be having, the impact it might have on your health, and also being able to analyze, to dissect the diagnosis, all the information that you'll be getting from your physicians. So, for example, just a quick discussion, but the common terms. For example, invasive cancer and non-invasive cancer, and that can be confusing for women. That invasive cancer is a cancer that has grown through the wall of a duct, because you have milk ducts. That's where the cancer starts, and then so the invasive cancer has grown through the wall. So once it grows through the wall, that means he has the ability of spreading, of getting into lymph nodes, or going beyond the breast into the lungs or other sites. On the other side, a non-invasive cancer, also you might hear the word in situ or in situ. The right presentation is in situ. Breast cancer, that's a non-invasive cancer. It's a cancer that's still confined to the wall of the duct. It doesn't spread. However, it needs to be treated, because if it's not treated, it will tend to evolve into invasive cancer that can spread, eventually cause damage to your body. Positive and negative, because usually we think that positive is a good thing. And I'll tell you a story that recently I had a young woman who had surgery, and then I was discussing the margins, because you have to make sure the tumor is completely removed. So I told her that the margins were positive, and she started applauding. And her mother was there, an older woman. She started, praising the Lord, that the margin was positive. I had to explain to her, no, that's not a good thing. We're aiming for negative margins. The margins have to be negative, not positive. So we have to, be used to this kind of discussion, that we're looking for negative results. For example, if the lymph glands are negative, that's a good thing. If it's positive, it's a bad thing. So we have to get used to this terminology. Stages of breast cancer. Stage of breast cancer gives you an idea of what the outlook, the prognosis might be. If the tumor can be stage 0, 1, 2, 3, or 4. Stage 0, that's the one we're talking about, the in situ, the non-invasive breast cancer that really hasn't grown through the wall of the duct and has no opportunity to spread to other parts of the body. That's stage 0. Stage 1 will be a tumor that's about less than 2 centimeters without any involvement of the lymph glands. So obviously the prognosis, the outlook would be better than somebody who's, let's say, has stage 4. Stage 4, which is when the tumor has spread to other organs, let's say to the lungs, to the bones, to the brain. That's stage 4, where the prognosis is not that good. We have to familiarize ourselves with the word hormonal receptors. That's a key now, because the patients can be treated with the chemotherapy, but it can be treated with hormonal therapy, which is better tolerated. So we look, to see the person has hormonal receptors that are, in that case, positive would be a good thing. Positive hormonal receptor, that's good. Negative hormonal receptor would be a bad thing. And that would help us decide what kind of treatment is best for the person. And we have to be aware of some myths that are being spread in the communities. And cancer is not caused by trauma. A lot of times people would present with a mass. They say, well, this is because I hit myself against the door or doorknob or something like that. And so therefore it probably just go away. No, it won't go away because breast cancer is not caused by trauma. If you feel a lump in your breast, better try to see your doctor as quickly as possible. Breast cancer is not contagious, because your husband has cancer or because your wife has cancer, he's not going to give it to you because it's not contagious. It's not a viral thing. It is a genetic alteration in your DNA that leads to the cancer formation. Some people think that, well, once I have cancer, I'm doomed. I'm never going to be cured. That's not true. That's a myth. Cancer can be cured, and with proper treatment, it can be cured. And some people will say, well, I don't want chemotherapy. I don't want radiation. I want to be treated with vitamins, change my diet. People talk a lot about juicing, and or I can join a prayer group. That's nice and dandy. I mean, prayers, are good because they help give you fortitude, they give you strength to go through the treatment, but that's not the main treatment. And change in diet, a healthy diet might prevent cancer, but once cancer is there, changing your diet is not going to make the cancer go away. And you have to change your diet. True, if you had an unhealthy diet, but at the same time, you have to do the regular treatment, be it surgery, be it radiation, be it chemotherapy, be it hormonal therapy or immunotherapy. All these things are important. People also, have the myth that, well, once you operate on breast cancer, it's going to spread. Again, that's, you have 1,000 cases that are diagnosed every year. And I would say probably 90% of these cases get some kind of surgery. And then if that were true, that means that 90% of the women will die of breast cancer. Operating on breast cancer does not spread the cancer, but helps treating it and helps removing it so that you can work towards a cure. And recently, a patient of mine, she was a nurse, but she still, believes in this myth. So everyone who receives radiation or chemotherapy dies. So therefore, I don't want to receive radiation or chemotherapy. Certainly, the person that died of cancer probably did receive chemotherapy or radiation, but perhaps the person waited too long, or the person had a very aggressive type of cancer. But this is not the radiation, the chemotherapy that killed the person, it's the cancer that killed the person. So radiation and chemotherapy are effective treatment, and therefore you should not reject these options for treatment. Some people think they might have the options of either surgery or radiation or chemotherapy. So again, that's a myth. You don't have this option. Sometimes you might have to combine them. Some people would need just surgery and radiation. Some people would need just surgery and chemotherapy. Or sometimes some people might need all three: surgery, radiation, chemotherapy, hormonal therapy. So it's not one, it's not going to throw a menu as well. I pick this one, I pick that one. No, it depends on the kind of cancer that you have, and whatever is the best treatment, that's what would be decided. So again, having an open mind is key. You have to listen carefully to the information that's being provided to you. Take notes so that you don't forget, because a lot of times with the you're overwhelmed with the news and the information that's been given to you, and you flustered and you don't hear, take notes, write down questions, and even when you go home, you might think of something you didn't think about while you were at the doctor's office. Write down the questions and ask the question. Have your questions answered? There's no such thing as dumb questions. Your questions deserve an answer. So again, bring a friend or a relative, because sometimes you might be so upset, so overwhelmed by the news that you might not be hearing what is being given to you as far as information. So once you get all this information, now you have to make other choices, choosing where to be treated and by whom. And that's very important. Some people would say, well, I want to go to the biggest cancer center in the area, and because they know more about cancer. Certainly, there are some rare cancers. There are some cancers that are really in a very advanced stage, where you might need to enroll on the trial, experimental protocol that might not be available in all the common clinics. But for the most of the common type of cancers, you can get the treatment locally. You have to think about glitter and gold, because you might have a center that's advertising on the billboards, on TV, 24 hours a day, and then we have this, we have that, and then when you go there, and then there's no empathy, there is no personal care, and you're a number, you're in a big room, and with the 20 other people, 30 other people, and you have the restriction and number of minutes you can spend with your doctor. 15 minutes you have to be out, 20 minutes you have to be out. So you have to think about all that. And also think about the access for yourself and the relatives. The person might have to travel long distance to go to that center, and it might be a difficult commute. You might have to think about the expense of parking, for whole day of treatment, and all these things. If you have to be hospitalized, will your family be able to come to see you? You have to think about all that when you're making your choice for where you want to be treated. And also, are you going to have a doctor? You have your doctor. Are you going to have every week is a different person that's going to be seeing you, and it's not really what you would want to be treated with. And cultural competence is very important. You have somebody who speaks your language, somebody who understands your culture, and somebody who is going to be the fears that a Haitian patient might have. They'd be different from the fears that an Irish person or a Korean person might have. So there has to be some cultural sensitivity there to really understand the culture, and that will go a long way to make sure the treatment is well received. So the team approach is very important. So as the breast cancer patient is in the center of all this, it's the main actor there. And then, as I mentioned before, usually the PCP or the gynecologist will refer to a radiologist, who do the mammogram or do the biopsies. And then once the diagnosis of cancer is made, and the person will go to a breast surgeon. And depending on the stage, the person might just need surgery, or the person might need surgery and other treatment, such as chemotherapy or hormonal therapy. Then the person might have a stage where the mastectomy is needed. I mean, you might have to remove the breast. Then you have to discuss with the person, is that okay that they would be without a breast, or are they going to want to reconstruct the breast? And then you have to speak with the plastic surgeon to that, and you'll have to have a discussion as far as whether do you want to have reconstruction or not, what type of reconstruction you would like to have. Or some people would prefer to just have they have bras with a foam in the bra And once they are on, you can't even tell. Impossible to tell the person had a mastectomy. So these are options that you have to discuss with the plastic surgeon. Radiation oncologist, sometimes, if you choose to preserve the breast, you might have to get radiation as well. That's part of the treatment. The oncology nurse will be probably having the regular contacts with you, because they'll be the one delivering the chemotherapy. If you do need chemotherapy, they'll be seeing you with your medical oncologist in follow-ups. Physical therapists, sometimes after the surgery, you might have some limitation in the range of motion of your shoulders, and you want to get back to your full function, and that you might have to do some physical rehabilitation. Sometimes you can do it by yourself, but sometimes you might need to go to a center to undergo rehabilitation. Geneticists, if you could see that there is a family pattern that several people in the family has developed cancer, breast cancer, ovarian cancer, and those are cancers that tend to go together genetically, and or this person has uterine cancer and the colon cancer, you can have breast cancer as well. That's another pattern that you might identify where there's a gene that's being passed on in the family. It's very important to identify that gene so that the other members of the family can be tested and see if they need to have surgery before they even develop the cancer. That would be the best way if you can, take care of the problem before it occurs, so that you don't even have to get any chemotherapy, hormonal therapy, radiation therapy, or anything like that. And so a social worker, you'll be very important in two ways, both because you might need some social services that are available and you might not be aware of. And the social worker might help you, might guide you through this different maze of regulations and social services that are available, and so that you make your experience more palatable, more bearable. But also, social work can work as a therapist along with the psychologist or psychiatrist, because going through all this treatment can be depressing. And depression is not a good thing. It might affect your compliance, it might affect your ability to tolerate the treatment. So it's good, to maintain your level of function, that you receive the proper support from this group of therapists. And again, nutritionists, it was important because during the treatment, you might not, the chemotherapy sometimes might make you lose your appetite, and then you might try to work with the nutritionist, what you could do to maintain your nutrition, because nutrition is very important. It helps you maintain your immune system, and so that you can fight the cancer better. There are other specialists also, because we talk about the beauticians, makeup. Sometimes, during the treatment, you might look pale, and you might want to have a makeup so they can, look better. It sort of boosts your self-esteem if you look better. If chemotherapy had made you lose your hair, and if you can have a nice wig that can, again, enhance your appearance and make you feel better. But having said all that, the bottom line, the support structure is probably, I would say, the most important, but very important part of your care. And again, the support system can be very important in all this, helping you get access to the care, helping you with the traveling to the destination, help you when you don't feel like eating, when you're vomiting, when you're not able to take your medication. Somebody's going to be there with you, holding your hand, help you, make you some tea, and give you on the medication, and make you feel better so that you can continue, go on with the treatment. So the support structure is very important. And so again, it can provide navigation, transportation, help you arrange your different appointments so that you can continue treatment, and help with compliance, as I mentioned before. And insurance issues that are very important, because sometimes if you have your insurance through to work, and then if you're unable to work, you might lose your insurance, and or might have to go on COBRA. How do you manage that? How you pay for it? Or if you lose your insurance altogether, how do you arrange to get some continuation through either Obamacare to Medicaid? Because it's very important that the treatment be completed. So the support can be given from individually. It can be from a friend, from family members. You can go on the internet. There's some blogs, and there's some hotlines. Like Adelphi University has a very strong, hotline that support women with breast cancer. You can have support groups that meet. I mean, they used to meet in person, but now probably during the pandemic, they probably meet by Zoom, and you can interact with other people. You have to be very careful though, because sometimes if it's a small venue, you might have people with different prognosis. You might have somebody who just had a stage 0 breast cancer, talking with somebody who has stage 4, and differently, the experience is different. And the person with stage 0 doesn't want to be depressed by the story of somebody who has a stage 4. And so it has to be defined by a stage, and also with similar affinities as far as diagnosis, and then culture, etc. The caregivers themselves might need support. Sometimes the daughter, is tired, is exhausted. She has to take care of her own family. Then she has to travel to go and take care of mommy, and make sure that she eats. You make sure that the house is clean, etc. And then there are a lot of resources available for the caregivers as well. So we have to think about that's a possibility. And so what other than that, what could affect the person compliance, because compliance is very important in the for the continuation of the treatment. So proper information, you have to educate yourself, a lot about your care, and that would help you understand what is being offered to you, what would be needed. And patient engagement, we'll come back to that again. Engagement means that you taking responsibility for your care, you sharing the decision with your doctor. You become your own advocate, and we'll come back to that later. And so side effects, there are a lot of ways to mitigate the side effects, to avoid the nausea, the vomiting, and the pain, and etc. The person has had a history of depression. That has to be ascertained, and whether there will be some ongoing treatment, either in form of medication or in form of therapy. That would also be an important factor for maintenance of compliance. And if you don't have proper follow-up by the healthcare team, that might be a factor also, because you need a doctor who's going to be on top of your test results. If you have a blood count that shows that you're anemic, you're going to react to it, and you're not going to wait until 2 months later when they see you to react to it, when you might be feeling tired, fatigued, for a long period of time. Insurance companies, we have to negotiate that, because sometimes they have restriction. They might approve some drugs and not other drugs that might be important to you, and it has to be negotiated. Sometimes you might have to change your drugs, your insurance companies, if they're not allowing the right treatment for you. Insurance co-pays, and then transportation, all this can be a factor. And the goal is to make this experience as doable for you. So we're talking about engagement and activation, and they have studied that there There are 4 groups of patients that have been identified. You can have the level 1, a person who is overwhelmed by the diagnosis, is disengaged, really doesn't want to know anything, and they just want to rely on the healthcare provider. My doctor is in charge of my health, so I don't have to know anything. I don't have to. I can come if I want to, or if I feel like it. If I don't feel like it, I don't come. So that's the worst situation, and as you can imagine, that the outcome might not be that good. And as a person gets more motivated, and the person might educate herself to learn more about the disease, but they still have some gaps, and there might be a mix of some myth that's still persisting in their understanding of the disease. And then you get to level 4, level 3, where the person is really becoming well educated with the disease and the treatment that she's getting, and she's helps making the decision, whether I'm going to get reconstruction, what type of reconstruction I want to have, whether I don't have any reconstruction, and whether I'm going to be going to radiation therapy to a place that's close to my house. And then you become your not master of your destiny, but also you become an important part of decision making. And level 4, that's the where we would like to have everybody, where the person is the own advocate. They can they can read, they can inform themselves, they go to seminars, they can do webinars, they learn about the disease. And in fact, sometimes they might even suggest to the doctor, well, I read this, what would that be appropriate for me to receive that kind of treatment? Or I see that this Merck is advertising this particular treatment. Would that be a good thing for me? So you become your own advocate, and that's where we would like to be. It has been shown to be very important. The person who is more activated, is less likely to be readmitted to the hospital, is less likely to be a victim of a medical error, and then less likely to have a health consequence because of poor communication among providers, because you will be the one talking between all the different providers, between your surgeons, your medical oncologists, your radiation oncologists, and the gynecologists, that to make sure that everything is coordinated, there is no gap in your care. So more activated, level 4, that's where we want everybody to be. And so that's the important, the engagement is very important, a part of the compliance, education, care coordination, and activation. Those are all the important factors that would make sure that you have a good outcome. So the support structure, as mentioned before, it can be a family member, it can be friends, it could be church, the clergy, prayer groups, online help, blogs. Again, I want to repeat that, be careful, because not all blogs or internet help is reliable. You might have people spreading false information. Particularly now, some people take a very curious enjoyment at disseminating fake news, fake information. So you have to be very careful. Make sure that you get a reliable source of information. So what would be the role of the caregiver in exchange? You have to provide support and encouragement, provide the medication, and helping manage symptoms and side effects, coordinating medical appointments, providing a right to appointments, assisting with meals, helping with household chores. It might help with the laundry or cleaning the house, handling insurance and billing issues, because the person might not be taking properly, and you don't want the, for example, bills for the rent or the mortgage not to be paid, and run the risk of losing your apartment or your house. Going to go. So coping with the outcome. So beside the treatment, you're going to be getting a treatment. Obviously, it's being proposed to you because it's been shown in studies to provide a good outcome. But things are being done to you, you're going to have an impact, you're going to have side effects. And then you have to see how you're going to react to this treatment. How are you going to continue? Are you able to continue to work? And are you going to be mutilated? You're going to lose a breast, and then is that okay? Is that going to make you depressed? Are you going to want to reconstruct the breast so that you can regain your self-confidence? And returning to workforce, plastic surgery might be important. Physical therapy, because sometimes people have, after mastectomy, you might have stiff shoulders. It might be difficult for you to work if you, for example, you're a nurse in the hospital or nurse's aide, you're having to pull patients, that might be difficult for you. Again, beauticians, we discussed that before. You might need to have makeup, wigs, and mastectomy bra with prosthesis. And you might want to regain your strength. You have a physical trainer, nutritionist, improve your diet, and also therapy. It can be in many different ways. It can be the art therapy, dance therapy, yoga, meditation. All forms are good, provided they can bring you that uplift that can help you deal with all these issues. And so, most of the time, as we mentioned before, 90% of the time, you're going to be successful in treatment. And either that through the standard, what's well established as hormonal therapy, chemotherapy, radiotherapy, immunotherapy. But sometimes if the disease progresses or does not respond to the standard treatment, you might have to go through experimental trial. Then in that case, you have to have an informed consent. You don't want to be railroaded into a trial. It's going to be very toxic, and without any consent. You want to have a consent. And then there are different forms of trials. You have phase 1, phase 2, phase 3, and that depending on the phase, there is more or less likelihood that the treatment might help. But nevertheless, if it doesn't help you, but at least it would help other people, because if you have reached a stage where the cancer is uncontrolled and curable, then by participating in trials, you might be able to help find a cure for somebody else, or even sometimes your relatives. So dealing with the failure of therapy. So unfortunately, as I mentioned before, when the cancer spread beyond the breast, either to the bones, the lungs, and the survival is 27%. So we have to reckon that some people are going to die. And then so when they get to a point where the treatment does not work anymore, there's no more therapy, you have to, how do we deal with this? You have to be able to communicate. Communicate is very important. And the person is going to be angry, is going to reject it, be in denial, but you have different phases. And eventually the person would have to come to terms with it, that everything has been done, and it's not in the likely that the person is going to survive. So you have to focus on making this transition as smooth as possible. It can be a hospice care. You might have to be home hospice. You can be at home in your own bed. You have 24-hour nursing services at your home, or you might have to go to a nursing institution, either a nursing home or a hospice, where they will be more adept at supporting you during this difficult time. And eventually, if that's the end point, we are going to die. And then once that is likely that could happen, at least it gives you a chance to arrange your papers, make sure that everything is done properly, so you don't have to live any turmoil in your family, any your heirs fighting each other, or having to go to courts, to decide who gets who. You might want to take care of that. But then once you're gone, then the survivors, they need therapy as well, because they have been hurt by the loss, and then they need to be supported. And all this is part of the care, going from the diagnosis to the end. So at the end, that's all I wanted to say. I wanted to tell you that breast cancer is the most common cancer among women. The better treatment and early diagnosis have led to improved outcome. The successful outcome requires good care, up-to-date comprehensive facility, personal care, no cookie cutter, and the treatment now can be tailored to the particular type of cancer that you have. Trust is key. You have to have a good rapport with your healthcare providers, good communication, and you have to be engaged and activated, understand what's going on, understand your disease, understand the treatment, and participate in it. And proper support, very important. Family member, friends, church, whoever is providing support is very important. And finally, I have to say that the diagnosis of breast cancer is just a bump on the road, not the end of the road. And those are, if you have some pen, you can make a note of this. Those are probably some of the most reliable sources of information that you can go to find information about breast cancer. And that's all I have to say.
And that was a lot, Dr. Auguste. Thank you so much for the excellent information that you've provided us. This is definitely a serious topic for our community and really for all communities. And you highlighted some really important points. I think last year we definitely learned this, and this year you emphasized it again, that breast cancer doesn't only impact women, men also get breast cancer. You taught us about the different types of cancers. You empowered us to educate ourselves about the cancer and treatments. You reviewed the psychological impact of breast cancer. And I really love the fact that you emphasize the importance of mental health and how mental health actually impacts the way that we receive the treatment. That's incredibly powerful. You even made us aware of the myths, right? Some myths about cancer and breast cancer. And that's really, really empowering. And more importantly, I think at the end here, you gave us hope that cancer can be cured with proper treatment and support structure. That support is just so essential. So I continue to invite the audience to share this live and save it, right? And come back to that information. There's no shame if we've been diagnosed with breast cancer. It's actually incredibly important. And Dr. Auguste, if you can talk a little bit more about how do we detect breast cancer? When should we go get a mammogram? And we'll be looking for more questions in the audience. If you can stop sharing your screen.
Sure. So the nowadays the most common way breast cancer is diagnosed is by mammography. And thank God, the message has been received, and women are really being more proactive. And 70% of the women do get mammograms, which is a big change from, let's say, 20 years ago. And we'll see the results. We diagnose this cancer at the earlier stage. So that's the most common way it's being diagnosed. However, there are other ways, and then you should be aware that the breast lump, okay, is something to be really concerned about. Anytime during your shower, as you soap yourself up, you palpate a mass there, don't ignore it. Don't try to diagnose yourself. Don't think, well, it's because I hit myself against a doorknob or a table, something like that, or it's an infection. I'm going to put some hot compress on it. It's going to go away. No, that's not you'll be wasting precious time. Go and see your physician, and he can do the proper test so that you can be diagnosed properly. So at what age you should start? The most association, most societies recommend that you start at 40.
Mhm.
40, that's like a general number. However, we know that in the African American community, the breast cancer tends to develop at an earlier age. Yeah, I see. I recently had the young woman. She was 29 years old. You know, she has breast cancer. So if you have a mass in the breast, even though you're 29 or 25 or 30, don't ignore it because you're young. Because young people can have breast cancer. So again, we're not going to recommend doing mammograms on everybody starting from age 25, but you have to be aware of the breast and examine yourself. And if you feel a lump, please go and see your gynecologist or your primary care doctor so they can be evaluated. And the other point also I want to make is that if you do have a family member, your mother, your sister, an aunt, you had breast cancer,
Mhm.
particularly if it was premenopausal, I mean, before age 50, then that increases the risk that you could have breast cancer as well. And so you're going to start screening earlier than in age 40, so that you can have a chance to pick up that cancer at an early stage. The other things we have available, we have MRIs that are available nowadays, because in a young person, the mammogram might not be very precise because the breast is denser. And a person
Okay.
with a strong family history might want to have an MRI of the breast so they can pick up the cancer.
So when we do that that self-analysis, or, we're in the shower, we're feeling around it just to see if there are any lumps, right?
Yes,
And it's
correct.
recommended that you lift up the arm to be able to access that. Is that correct,
Correct.
Dr. Auguste?
So you can either do it, while you're in the shower, and because then usually with the water and the soap, it might be easier for your hand to glide over the breast, and
Okay.
you lift like you said, you lift the breast because that
Right.
spreads the breast tissue over the chest wall, so you have less breast tissue to deal with. Or you can do it, lying down. That's another way of doing it, and I think I like that, even better. When you lie down, and you can also lift your arms. Again, the main purpose of doing that is because you want to spread the breast tissue over the chest wall. It's less thick, and you can palpate the mass, if there is one, more easily.
And that is so incredibly important. So those of you who are on this live, please today, right, screen yourself. You lift up your arms if you're taking a shower, or lay down as Dr. Auguste said, and get to know your breasts. Get to know your breast. There's no shame in that. Get to know your breast, because that is early detection, right? The earlier we detect that there is an issue, the easier the treatment will be. One of our viewers, Dr. Auguste, asked, she actually stated, "I'm hesitant about getting a mammogram because my breast would feel uncomfortable. Is that normal?" So tell us a little bit about the mammography. I have to tell you that many of us, especially those of us with dense breasts, we do feel a sense of fear around the pain and discomfort around the mammography. Can you speak about that yourself?
Sure. Unfortunately, there is no other way, no substitute to a mammogram. And fortunately, you only have to do it once a year. And so I encourage the person that has some people have very tender breasts. You can take a leave before, you can take some Motrin beforehand. And but they say no pain, no gain, and that you getting the opportunity to detect a cancer at a very early stage, and I think it's worth it. And if you don't do that, you wait for the mass to become palpable. You're going from stage 0 to stage 1 or stage 2, where the probability of survival tend to decrease already. So again, you have to psych yourself up, when you do it. But I really do recommend. I encourage women to go and have the mammogram. And again, if you meet certain criteria, you might be candidate for an MRI. The MRI does not cause any pain because you lie face down, the breast go into two cups, and the machine scans the breast, and it, but the is not a substitute to mammogram, but it adds to the mammogram because it's very precise.
What about
And also
men?
somebody with the dense breast, they want to have a sonogram as well, because
Okay.
the 80% of women tend to have dense breasts. I'm sure I don't want to be personal, but I'm sure you have dense breasts. So if you have a mammogram, you should have a sonogram as well.
Okay. Thank you so much for sharing that. What about men, right? Men, how do men detect cancer? How do doctors, right? What do they get a mammography? Do they get the MRI? Are we recommending that men do their self-examination as well around their breasts? What do you recommend, Dr. Joseph?
Sure.
Dr. Auguste?
So breast cancer is a lot less common in men. So usually the screening protocols tend to address the most common cancers. So for men, common cancer will be prostate cancer, colon cancer. That's the thing you would be screening for. But you don't do screening for breast cancer in men. However, there are some. However, there are some signs that you have to pay attention to. Any lump that you develop in the breast has to be taken very seriously. Again, don't believe that it's some infection or something like that. Any lump in the man's breast should be addressed. The second thing that you have noticed in women with breast cancer, in men with breast cancer, is bleeding. They have blood coming out of the nipple. And those are the two things. Lump and blood out of the nipple, those are things you cannot play with. And the one thing you have to also be aware of is that you do have genes like the BRCA gene that can increase your risk of breast cancer. It tends to run in families, not only in women, but in men as well. So that if your mother tests positive for the BRCA gene mutation, and then so all the children, men and women, should be tested for that gene, because then there's not everybody will get it because it's a 50% transmission rate, but so it's good to know to have everybody tested, so you know who will be carrying that gene, who will be passing it on, and to other family members.
Thank you so much for mentioning the BRCA gene. As a matter of fact, one of our viewers asked, if I have a history of breast cancer in my family, what age should I have a mammogram done?
Okay, so that's what I was addressing earlier, is that the general answer to that would be that you should start 10 years before the age at which the family member had cancer. For example, if your mother had breast cancer when she was 35, you should start doing mammograms at age 25. And that would be the general. If she was 40, then you start at 30. That would be the general answer. But now, the thing we want to do, if the person has cancer at an early age, is a very good likelihood that they may have a genetic mutation. So we have the ability of testing them for that. And then if we find that they do have a genetic mutation, then we'll be doing MRIs for them on a regular basis. And once they pass the childbearing age, or once they mentally ready for it, they might need to have the breast removed prophylactically before they even develop cancer.
Right. So now we're talking about possible treatments, right? One of the viewers asked, at what stage of cancer is radiation required?
Okay. So then when you have breast cancer, and then the treatment that has been used since the 1900s, 1887, was to do a mastectomy, remove the breast. And then so over the years, as people became more diligent about getting screened, we started getting tumors that were smaller and smaller and smaller. So you don't need to remove the breast every time. So if the breast is small, if the lump is small, you can remove it. But once you remove the lump, you want to do radiation as well. So the option would be either to have a mastectomy or lumpectomy with radiation. That would be for the like early stage breast cancer. Now, there could be other indications for radiation. Let's say somebody has the cancer that has the gone out of control, and they get to a point where the cancer has grown through the skin, ulcerated, and bleeding. You might have, because the radiation kills cancer cells directly, and then so you might want to do that in order to stop the bleeding, to get the tumor to shrink, or get the wound to close, etc. But generally, the radiation can be given for stage 0, stage 1, stage 2, stage 3, and less likely for stage 4. But unless the person has a wound that needs to be treated in order to heal. But they would give radiation, let's say, if you have the cancer spread to the bones or spread to the brain, you might have to get radiation to the bone or to the brain for that. But generally, for a person with early stage 0, stage 1, stage 2, stage 3, you can either use lumpectomy and radiation versus radiation. Versus mastectomy. And in addition, they have shown that if the person has cancer that has spread to the lymph glands, then you might want to add radiation even if you've had the mastectomy.
Okay. So the radiation can also supplement some of the other treatments that are there to ensure the effectiveness.
Correct. It's in addition, yes.
Well, thank you so much, Dr. Auguste. You have given us so much information. Every year we bring you here because we know that you are an expert in the field and you are just so rich with information. What advice would you give our community to ensure that they remain healthy and to take care of their breasts, and also to encourage them that, listen, if we are diagnosed with breast cancer, whoever you are, that you have the support. We're here to support you. Who can they go to? I know you shared some resources, so please share your wisdom with us as we wrap up tonight.
Sure. So first, you have to be aware of your own self, aware of your family history. And again, you like you mentioned, for regularly, do your self-examination in the shower or when you're lying in bed. And but also know your family history. And a lot of times people tell me, well, my mother or my aunt had surgery in Haiti, they may have had cancer, I don't know. Try to know exactly what your history, because that determines the risk that you may have to have a cancer yourself. That's number one. Number two, avail yourself of the screening protocols. They have, as I said, they have the American Cancer Society has put out recommendations for the most common cancers for men and women, and then you have to follow these recommendations as far as mammograms, colonoscopies, pap smears, all these things. If you're a smoker, when you should have a CAT scan of your chest, and all these recommendations are geared to pick up the cancer at an early stage when it's most treatable. And so my third thing is that try to fight those myths. Those myths are really dangerous because they are impediment to proper access to care. People would delay their care because they have this myth. They fear that nobody can be treated. Everybody with cancer, you're going to die, and that's not true. You're not going to die. There's treatment available. They have made a lot of progress, and we have surgery, we have radiation therapy, we have hormonal therapy. Hormonal therapy doesn't make you lose your hair, doesn't make you susceptible to infection, and it can be very effective if the tumor is hormonal sensitive. And you might have immunotherapy. There's some types of cancers that have different mutations in them, and there are specific medication that can be treated, that can be used to treat them effectively. So understand that you may not know everything about the cancer because that's not what you do, but look for somebody who has the information, somebody you trust, somebody who's going to guide you in your journey. And also don't be afraid of sharing your fears, your concern, and don't be afraid to lean your head in the shoulder of somebody else, because support is very important. That helps you cope through this difficult problem.
Yeah, it's really, really great advice, and that's why we call the women and men, the men and women, who have fought cancer, they're survivors, and people are survivors and they're thriving after cancer. I know many people who have survived cancer and have used it as a life lesson, and they were able to survive and they're thriving now because of experts like you, because they heeded the advice of their doctors. They were able to pull their strength and comfort from their support system. Right. And it's really interesting, Dr. Auguste, that you must have many women in your life, because one of the pieces of advice that you gave was, you talked about the beautician, you talked about feeling good, you talked about confidence, you talked about, a therapist, you even talked about a makeup artist. So Dr. Auguste, that's really cool. you know that it's really important for us to feel good.
Absolutely.
And if you're
Absolutely.
right. If you're out there and you are a woman or a man and you are battling cancer, know that you are not alone. It is important to feel good. It is important. And that starts with the way that we look and we feel, especially some of us, if we're losing our hair or different changes that are happening in our bodies. There are so many people out there who are there to support us. So I thank you so much. And the research continues. So as we continue here with this evening, as we end here this evening, let us really focus on the research. HAUP participates in examination as well, mammography. We've done that over the years. HAUP is celebrating its 46 years in the community, providing not only information, but services, health services to us. So please take advantage of it. Heed to Dr. Auguste's call for self-examination and early detection, because the earlier we detect the issue, the easier it is for us to address it. And certainly, and I don't mean easy as, oh my gosh, this is easy, because we know this is a very serious and difficult situation, but it is much better for your medical team to be able to address the issue faster. And we talked a little bit, I don't want to let you go, Dr. Auguste. One more thing, we talked about the COVID-19 and the impact, right? Because we were not able to get to the doctor immediately. So if you suspect any discomfort, again, we continue to encourage you to get support. If you can speak to that as we share with the audience about the walkathon that's coming up.
Sure. So, in fact, this COVID thing has made a big impact on medical care in general, particularly in cancer care. As I mentioned to you before the presentation, is that the patients with breast masses wouldn't go out of their house because they feared that they would get COVID. They wouldn't go for mammograms. They didn't go to the doctor. They wouldn't go for a biopsy, and the tumors tend to grow. And then when they started resuming a full operation back in May or June of last year, then we're seeing a lot of cancers that were larger and more advanced than with spread to the lymph glands than we had seen with previous years. So there are some a lot of centers that continue to operate. There was they took all kind of precautions, and then so you have to seek those places, and then where they have proper precautions as far as masking, as far as screening for COVID, as far as wiping all the facilities with the alcohol and Clorox, and where they have all kind of shields available. So you have to find where that's available, and then don't delay, because any 6 months delay is going to have a large impact on your survival. And again, that was calculated. There are several studies that shown how the 6 months delay in treatment, took away years of survival in the be it breast cancer, colon cancer, or other different kind of cancers.
Absolutely.
So that's a call for vaccination. Please be vaccinated, because we don't want to be back to that point again where you have to shut down the hospitals. We have to shut down all kind of care because of the hospitals being overwhelmed by COVID cases.
Absolutely, absolutely. So get vaccinated, and you can do that right at your local HOPE. So the HOPE office. So we have offices in Brooklyn as well as in Queens. Please, please, please get vaccinated, and again, conduct your self-examination. We are absolutely engaged in fundraising for breast cancer and breast cancer awareness and breast cancer research. So please join our walkathon. Dr. Auguste, we're inviting you also to join our walkathon. And I know that you are a researcher, you are an oncologist, you are a surgeon, and you do this work. And I know you understand also the level of funds that are needed to do that. So again, we're excited to invite you to join us on this fundraiser walkathon. And why walk, right? It's not only important for our health, right, to walk, especially now with the threats everywhere. When we walk, we smell the fresh air, we become healthier. It actually increases our positive hormones, and it does away with cortisol, but we're also walking for a good cause. If you have someone in your life who's been impacted by breast cancer or any type of cancers, walk for them. Walk for them, right? Walk for members of our community. Let's continue to encourage, health and wellness within all of our communities. So we're asking you to commit to walking to 21,000 miles for the month of October. You know what? We may actually extend this to the month of November as well, because that's how important it is to us. So please visit us at hopeinc.org /walkathon. You can donate, and you can absolutely walk as much as you can in honor of our survivors and also for breast cancer research. So please wait for a word from our organizer, Vanessa Jean-Paul.
Hello, everyone. My name is Vanessa Jean-Paul, and I am one of the board members here at HOPE. I wanted to take this opportunity to remind you all that HOPE's virtual walkathon breast cancer walk is still very much in full effect. Please join us through the end of this month. Yes, that's until October 31st, as we continue to raise awareness and honor those who have been affected by breast cancer. This is also a good opportunity to bring your friends and family together as you raise funds and support a great cause. To learn more about this event, please visit our website, hopeinc.org, or our Facebook and Instagram page. I hope you choose to walk with hope. If you are unable to take part in the event, please remember you can always donate. Thank you for your support.
Thank you so much for joining us this evening. I know that you found this very informational. Thank you, Dr. Auguste. You are always so brilliant and so caring for our community members. We'd like to invite you against domestic violence. We are engaged in a fight against domestic violence again on Thursday evening at 7 p.m. Please join us, because you never know. So many women are suffering in silence. We talked about breast cancer, which is your physical health. But now we're talking about a very important factor in our community that goes unnoticed at times because of shame or guilt. There's nothing, absolutely nothing to be ashamed or guilty about. Please join us. Let's get empowered together on Thursday at 7 p.m. We are here to support you. If you know of anyone that you suspect may be engaged in a domestic violence situation, please invite them to join the call. Again, thank you so much, Dr. Auguste. We'd like to thank our producer, Miss Melinda Placide. We'd like to thank also Sabi for his presentation today. Have a good evening, everybody. Thank you.
Good evening. Thank you.